there's a lot that we could do to create new opportunities for people to pursue careers in dentistry. And there's a lot we could do to enable a more productive mix of skills in relation to dentistry.
How do we track and reward prevention and outcomes?
It ought to be that we have got several therapists for each fully qualified dentist in order to have the most productive workforce, given that therapists can do so much of the work that dentists can do with the right supervision.
So, hello and welcome, and thank you for joining us for this special edition of the Probe podcast. Today we're going to be exploring the future of NHS dentistry, but really in the wider context of system reform and innovation. And I'm delighted to be in conversation today with someone that has not only led some of the most important thinking in public service reform over the past 2 decades, but has become a vocal and credible advocate for dentistry as part of the NHS. Matthew Taylor, Chief Executive of NHS Confederation, a membership body that brings together all parts of the NHS system, from hospitals and mental health trusts to ICSs, community services, and yes, increasingly primary and dental care providers. Before joining Confed, Matthew advised Number 10 as the head of the Downing Street Policy Unit, and has also spent, I think it was up to 15 years, as Chief Executive of the Royal Society for Arts, Manufacturers and Commerce, a globally respected organisation which is focused on social innovation, civic renewal and solving some of society's most complex challenges. In short, Matthew brings a system thinker's lens to the NHS ecosystem. He's consistently championed better leadership, better ideas and better outcomes for patients and communities. And I can't think of a better person to have alongside me today. So Matthew, great to have you with us.
Thank you. And thank you for those kind words.
You've recently described a window of possibility for NHS dentistry, and that certainly caught my attention and many of my colleagues in the profession. And I quite like to start there because it's not something we've heard from national leaders, let alone the centre of the NHS system thinking. So what's changed? Why now? And I'd love to sort of get under the skin of NHS Confederation and what it sees in terms of dentistry. Are we still an adjunct or are we central to reform?
Well, let me say a little bit about the Confed and then get into the question you asked. Thanks. About this window of opportunity. So the Confed represents leaders from all parts of the health system in England, but also in Wales and in Northern Ireland. So we represent all different types of trusts: acute, community, ambulance, mental health. We also represent primary care, and indeed our activity in the kind of primary care space has grown, and that's the whole of primary care, including dentistry. So that's who we are. What we kind of do, I think, is we're very focused on integration and collaboration. So whilst we represent individual organisations, we're wanting to always work between organisations because we don't think any of the problems that the health service has, or any of the problem that the people who are driving the greatest demand in the health service, the greatest need, people often with long-term multiple conditions, we don't think any of those problems can be solved if we can't work more effectively together. And that's something which is a theme, I think, also in the 10-year plan. I think the final thing I'd say that's distinctive probably about the Confed is we think the NHS is only part of the challenge of improving the nation's health. And so we work closely with colleagues in local government. We have someone on secondment from the Department of Work and Pensions, for example, in the Confed working on the agenda around work and health. We're working with some of the mayors. So we try. It's very hard, I know, because I used to work in government. It's very hard if you're a department to reach out beyond the boundaries of the department. But actually, if we want to improve the nation's health, we have to work across government at both a national and a local level. So we do that kind of reaching out work because ultimately It's the nation's health we want to improve, not just the nation's health service. Now, in terms of the window, I mean, I guess there are two parts to this, one negative and one positive. So the negative is there's a window of opportunity in the sense that there's also, to mix my metaphors, a burning platform.
Yeah.
We know the shocking figures on the number of people admitted to hospital due to tooth decay, and up to a third of those are children aged 5 to 9, which is a tragedy in itself for a child to have to go through something upsetting and worrying like that. But also we know that the earlier these health problems emerge, the more they beset you through the rest of your life. We've seen a significant rise in oral cancer over the past decade, and we all know that the critical thing with cancer is identifying it early, and that's what routine checkups can do. We see more complex and costly treatments. So we have this combination of dental deserts and more people doing kind of DIY dentistry at the same time as we've also seen greater complexity in terms of the care that people are receiving. So then there's even a link to elective waiting lists, because too often the reason people are not able to have an operation that's been scheduled for them is because their oral health is so bad and the risk of infection so high is that they can't proceed. So there is a burning platform. And when I looked at, and I hope I'm not being indiscreet here, but when I was given a chance to look at earlier versions of the 10-year plan, various people at various times were brought in to look at various bits of it. It seemed to me that there was a real gap in terms of dentistry. And I think that probably reflected, Sarah, a sense of intractability, a sense that this was just an impossible issue. One of those issues where the only thing you could do was throw money at it, and there isn't enough money. And actually, and this is where we get to the positive side of this. I think one of the things, and it was by far, and it wasn't just me or the Confed at all, but I think one of the things we were able to say that started to shift that, which meant the 10-year plan had a lot more to say about dentistry, albeit at quite a high level, was that actually, yes, there's a financial issue, and we can't avoid that. And we know the financial situation the country is in, the NHS is in, and dentistry is in. But there are things that you can do to make a difference, to think about this problem in different ways, which aren't primarily about money. They're about things like, a more intelligent forms of commissioning, which focus more on outcomes and less on activity, a theme for the health service as a whole. It's around how do we think about dentistry? And this was there were two big things for me, because a lot of people talk about the contract, but two big things. So how do we think about dentistry as part of this concept of neighbourhood health? And I don't think anyone had really done that. I don't think that people just in the centre had not really made that connection. Well, could dentistry be part of the neighbourhood story? And then the final thing, Sarah, was something which was an insight that I got from a trip to the excellent facility in Suffolk, and that was around workforce, and that there's a lot that we could do to create new opportunities for people to pursue careers in dentistry, and there's a lot we could do to enable a more productive mix of skills in relation to dentistry. So, those three things: contract reform, dentistry in neighbourhoods, and thinking much more imaginatively about the workforce was what we kind of brought to the table. And I think that and various other things led to a kind of light bulb moment for the 10-year plan.
You've given us some really powerful framing. We talked about the three big pieces that sort of surfaced during the evolution of the 10-year plan, and I sense you will recognise my frustration, having spent 7 years in that system, pointing out those very issues. And interestingly, my time with the military, where we had oral health fully integrated into our community health of our personnel. We also worked on outcomes in terms of how we employed a huge variety of our oral health staff. So for me, bizarrely, we're not necessarily doing anything new. It's just not been done in the NHS. And as you know, I have a declared interest in Suffolk, where we were delighted by your visit. But all the things that we're putting into Suffolk in terms about outcomes, a different type of contracting, full use of our dental therapist, utilising our dental nurses to do the prevention, and being a prevention-led service. For me, it's great to see that the 10-year plan has caught up in the thinking. I'm not necessarily sure that everyone has connected the dots in quite the way that you at NHS Confederation have. And I do see very much your ability to help bring in to the big conversations about NHS where oral health and dentistry sits. And, we've talked previously about the dividends. You say it's not necessarily about money, but we know that we invest in the oral health of a type 2 diabetic. We can actually reduce their HbA1c by 0.4%, which is exactly the same trigger for dual drug therapy, which then delivers you a dividend of £1,500 a year on that patient's pharmaceutical bill. So the dividend actually might come in a different part of the NHS forest. And it's great to hear you connecting those dots, because I think we've all felt in the profession as a lone group of advocates, and the allyship of NHS Confederation, the platform you offer oral health, is amazing. And I think for me is the 10-year plan is great. We've all had strategies before, but the real test for me now is how do we collectively create a real lever for the tangible change? I mean, the question I suppose to come back to, what is it going to take for us to get that national vision and what you've described in terms of the three elements you've discussed into a local reality? How can the profession work with NHS Confederation or ICBs to make sure we get this dental reform piece seriously embedded in our transformation agenda for ICBs, or more importantly, thinking beyond it's the contract that's at fault? How do we embolden ICBs to say, well, actually, there's a different way to commission, as indeed Suffolk and North East Essex have done?
So, let me respond to that question, Sarah, to kind of at a kind of the level of kind of change and politics. I don't mean capital P politics, small p politics, in terms of how is it you kind of build momentum for change. So, I've talked a bit about two bits of this. So, you build momentum for change by being clear there is a burning platform, and that steady state, there is no, default of sticking to what you're doing. You build it with hope by saying to people there are actually things that we could do that would improve things, and that are possible. I think you then have to have a coalition. And this is often very hard, actually, in the health service. You need to build a coalition of clinicians, of managers, of experts who bring particular insights to this, maybe from the think tank community, and also, I think, the voice of the patient and the public. You need to build a coalition of people who recognise that they agree about a lot more than they disagree about, and that they can focus on the things that they agree about. And then I think it's going to be critical at a local level to bring partners together to reimagine how we can do things, and to develop solutions, and to be able to actually bring those solutions to ICBs. And the reason I say that is that, we are the membership organisation for ICBs, and they have clearly been through an incredibly difficult process. 50% cut, reorganisation. They are now, as I speak, stuck in a position where they've been told they've got to make redundancies to balance the books, but then those redundancy packages are not being funded. They're not even being approved by the Treasury. So, it's a really, really difficult situation. And one of the questions actually that's wound up in all of this, one of the areas we haven't really got clarification around is in terms of commissioning, pod commissioning. So, is that something that ICBs are going to be funded directly to do or not. So if we rely, there will be ICBs, and there are ICBs, like we see in Suffolk, who've really got their act together and want to do this differently and have the confidence to do so. But there will be lots of other ICBs that are so caught up in levels of change, so caught up in all the other things they've got to do, that if what we present them with is a set of difficulties and questions and problems, we may not get very far. So what we need to be doing is we need to be presenting them with solutions, and we need to be saying to them, there are partners within your systems, within your places, who are ready to talk about solutions.
No, absolutely. And I'm certainly aware of the slightly more braver, I'm going to call them, ICBs, who have certainly been to look at what's happening in Suffolk, looking at what's happened down in the southwest, where there's another community interest model. And I think I'm sensing that ICBs are looking for new providers to come in with new solutions. It's don't tell us what you don't want. Tell us what we can develop together, and absolutely, echoing everything that you've said there. And it's really helpful to appreciate that for the profession's point of view, that there is a sense of momentum, but that momentum isn't just about us standing in the doorway. It's walking through that doorway with our other colleagues. And certainly you mentioned POD, pharmacy, optom and dental. I sense, some parallels across those areas, certainly with optom. And again, thinking more collectively about how those three professions in a place can work together. You mentioned interestingly the patient voice, and obviously there's some concern about the what looks like or is the demise of HealthWatch and how we get the patient voice out there. There are a number of patient groups I know that have worked very closely alongside the dental profession. So, for me, great, it's going to have some bold moves, understand the barriers. And yes, I just hope we're going to move from naming the problem to actually reshaping provision. And in reshaping provision, we've talked about contract and how performance is managed. And I think, again, and you spoke about it, how do we track and reward prevention and outcomes? We know that if you can keep a child caries free to the age of 11, they're likely to remain caries free right the way through to their adulthood and then beyond. Now, that has huge cost implications because you're not drilling and filling and repeating. We also know how much it costs to put a child through a general anaesthetic, an eminently preventable disease. We introduce things like dental check by one. We've introduced things where we are actively working with families to be able to support that access to care. But again, the current system, the units of dental activity system, is a widget counting, apple picking factory line. And I think we all want to move away from that. And what strikes me as you talked about broader NHS commissioning and commissioning for outcomes, I suppose my question is, what do we know that the ICBs already have that's a commissioning model for outcomes? And is there utility in thinking about, well, we do that for outcomes in one area, can that be translated into the oral health arena? Question, I don't know. It's the complex of lawyers and judicial reviews.
Yes. So let me answer that question, Sarah, but then let me throw back a question to you, because I'm really intrigued and in some ways you've got more credibility than me in answering the question I want to ask you. But in terms of the first point, ICBs will become strategic commissioners. And in the process of becoming strategic commissioners creates an opportunity to really ask themselves, what are we commissioning here? Are we commissioning the right things? And that is the opportunity to say, look, what we need to be commissioning is prevention and outcomes, not activity. And how do we do that? And how do we work with the profession and our partners to do that? And I think, part of that is when we talk about neighbourhood health, people will hear this phrase neighbourhood health, and there's a danger that neighbourhood health just feels like yet another term, primary care trusts, primary care networks, now neighbourhoods, single neighbourhood providers, multi-neighbourhood providers. while we're just kind of repackaging things, which is why we at the Confed have said from the very beginning, ultimately neighbourhood care has got to be about a different model of care and a different relationship with the community. And if it's not about a different model of care and it's not about a different relationship with the community, then it may not be even worth the effort. And central to that is particularly in the more deprived neighbourhoods. And I make absolutely no apology for the fact that when it comes to public policy, I'm always much more concerned with, what is happening for the bottom 30%, what is happening in the poorest communities. Middle class people like me can, generally speaking, sort themselves out one way or another. And, the NHS has got to have an offer that is strong enough for middle class people because, as Richard Titmuss famously said, a service for poor people soon becomes a poor service. So the NHS has got to feel like it's there for everybody. But we need to focus on those people we're most letting down, and when we think about how we deliver services. And so central to neighbourhoods is a more proactive model and a more holistic model. So I'm really inspired, for example, by the Chewies model, the so-called, it's interesting pun given we're talking about mouths, but the Chewies model they have in Westminster and other parts of the Southwest, other parts of London. That model is a model of Chewies that stands for community health and well-being workers. They are out literally knocking on doors and having conversations with families around all of the kind of potential health issues they've got, and not just the direct health issues they've got, but also the other challenges which might be driving their health issues around debt and around housing and around poverty and around diet and all those kinds of things. And it works. You've got to be patient. You've got to take time. You've got to win the trust of the community. And I think that oral health absolutely needs to be part of that. So I think when the Chewies are out and they're knocking on doors and they're going and the families trust them and they're coming in and they're saying, let's think about you as a whole family and what you need and how we can work with you as a whole family. One of the things they need to be looking at is oral health. Absolutely. So for me, that's part of it. And then the second part of this different relationship is, a more holistic offer, because 70% of demand from the health service now comes from people with long-term multiple conditions, and that's going to even rise. But yet so often these people who have several needs, mental health needs, physical health needs, social needs, we meet them one need at a time. They go into the system, they come out of the system, they come back, they keep bouncing in and out, and their needs are not met as a whole. So the other thing is, by integrating oral health and dentistry in the neighbourhood offer, it means that when we talk to people who've got one condition, we have an opportunity to talk to them about other conditions, or as you precisely said, so we can recognise the way in which oral health is implicated in both the disease, but also potentially in what you need to do to help people, get over that disease and to live in a more healthy way. So that has got to be the vision. Now, the question I guess I pose back to you, Sarah, is in this, dentists as a community, as a profession, are an incredibly important force. And, one of the things I've written about and I've said is that, I'd not really come across the concept of dental therapists until I went to Suffolk, and meeting that group and seeing the unbelievable number of people who want to go on that course. I think hundreds and hundreds, and there's only 24 places a year. And then, standing back from this, and forgive me for being simplistic, it ought to be that we have got several therapists for each fully qualified dentist in order to have the most productive workforce, given that therapists can do so much of the work that dentists can do with the right supervision. But in fact, we've got the reverse ratio. We've got many more dentists than we've got therapists. So there's a real opportunity there, as there is an opportunity around having dental nurses who lead on oral health in neighbourhoods. But as we saw with the PA's, psychodrama, well, not just psychodrama, it's been an incredibly toxic and difficult issue. Whenever you talk about workforce reform, whenever you talk about enabling more people to work at the top of their practice, whenever you talk about the most qualified people focusing their time on the work that only they can do, you start to stumble into the territory of people saying, well, hang on, this is watering us down, this is going to lead to be second rate, you're attacking our professionalism, all of this kind of defensiveness, some of which is justified and some of which is not, comes into play. So I guess my question for you, sorry it's so long-winded, is how do we best bring the dental profession into this conversation in a positive way?
So, Matthew, I don't think it's going to be difficult to bring the dental profession into this way, because dental therapists, since 2014, under the GDC regulations, had what's called direct access. Now, the irony of it is the NHS, under its archaic bureaucratic set of regulations, actually restricted dental therapists from opening and closing courses of treatment that fell completely within their scope of practice. We have an extraordinary number of therapists currently on our dental books, on the GDC register, who are all chomping at the bit, to use again the pun, to be working at their full scope of practice. But they are finding the limitations, certainly in terms of NHS contracting, again, a bureaucratic UDA, who can sign on, who's on the performers list. So bizarrely, Matthew, to me, the first group of people we actually need to bring on board is not the dental profession, it's actually the NHS regulators. Now, we did, to all respect to a couple of the individuals in Department of Health, did create a little chink, and we did create a clarification about direct access under the NHS regulations just back in 2023. We've also changed the exemptions from prescribing, which again has broadened the piece. So for me, and again, I raised this in my submission into the 10-year plan, there are a range of things we could be doing. So first and foremost, yes, absolutely, let's expand and support the training. Let's expand and support also the training in communities. Because one of the things we're not doing is actually encouraging dental practices to open their infrastructure to allow the support of dental therapy training. Because again, the tariff, as you've heard at Suffolk, is different. So that I believe actually there's a lot of bureaucratic barriers. Yes, there will be some professionals who prefer their model of working, their way of working, which, if they qualified in the 1980s, they're probably going to still want to think about what has been a comfortable, safe and quality proven service for them. So I think we need to start with the next generation, but this all is dependent on having the right clinical infrastructure. As you saw at Suffolk, a 10-chair dental centre can actually be manned with 4 dentists to 6 therapists. You can then create a flexibility in the workforce. You can have shared care. Again, the NHS contract has been very much one patient, one practitioner, one clinician, one course of treatment, one payment. And we know that isn't how it works in the big wide world. Patients are on care pathways, not on courses of treatment. Patients need to see the right person with the right qualifications at the right time. And that doesn't necessarily mean it's got to be the most expensive person in the building. So we do need to think differently. I think we've got a blueprint in Suffolk, and I'm not here to advertise Suffolk, but I do think there's blueprints in other parts of the country. This input has been offered into the system. They haven't necessarily always had the time to listen, because dentistry doesn't necessarily always float to the top of everyone's agenda. It's certainly in the top of a lot of MPs' post bags. I get that. It's
also a big thing driving public dissatisfaction.
Sarah,
that's
So I have always been one for challenging orthodoxy, and I go back to the model that we used back in 2005, where working more effectively within the military and our dental resources, working with our medical centres and our, even the guys that worked in the gym, who did we need to look at? How do we integrate the care into a training pathway for a recruit, a trained soldier to get out? We were able to take the military from, at that point, what was a 45% ability to fit to deploy, to 85% fit to deploy, because we took our existing resources and we reorientated the service. I know that we can do this. And, the support of NHS Confederation to challenge the orthodoxy of thinking is so refreshing. Your call to action, I come back to the first premise. I don't think you need to persuade the profession. whether it's therapists, oral health promoters, we all believe that there is no health equity without oral health equity. We're ready to play our part at local level. But the offer at the moment to just deliver widgets, to drill and fill, doesn't actually give any of us professional satisfaction, and it certainly doesn't deliver what patients need. It doesn't delete, it doesn't it. We're on the same page. And how do we get the system to listen is what I suppose I get my frustration. Sorry, it was going to come to this at the end.
Oh, look, let's celebrate the fact that the 10-year plan at one stage was going to be almost silent on this issue. And instead, there is real ambition there. Let's be realistic and responsible about the fact that we are going to have to come up with solutions. Confed, the more colleagues we have from dentistry who are part of the Confed, so they can bring their practical knowledge, their insights, innovators, those people who are bringing together federations of dental practices, creating that coalition of change. So Sarah, we are really committed to this. We've got momentum.
So I think I'd like to say thanks, Matthew, and thanks to the Probe for the invitation to have this conversation. I think it's easy, especially in dentistry, to feel like you're working in a silo. And often, yes, we feel like we're at the margins of a big system, and a bit more importantly, big system decisions. But conversations like this with Matthew remind us that oral health is health, and that the future of the NHS depends on our ability to think beyond traditional boundaries, certainly clinical, organisational and cultural. And Matthew's given us some real insight into the allyship that NHS Confederation offer us. So whether you're a commissioner listening to this, and I hope you were, whether you're a clinician, a policymaker, or someone that is just simply passionate about getting it right for patients, my ask is that we keep oral health at the table, on the table. We keep prevention at the forefront, and above all, we keep working together to put the mouth back in the body, because that's where it's always belonged. And maybe with a 10-year plan, we'll actually start putting money where the mouth is too. So thanks very much. It's been great talking to you. And Matthew, again, it's been a delight. Thank you.